Good day. Thank you very much for tuning in. My name is Dr. Kevin Stinson. I'm the Program Manager of Infection Prevention and Control at St. Mary's General Hospital and Grand River Hospital in Kitchener, Ontario. I'm also the chair of our clinical rounds program through IPAC-CSO chapter. This is a recording of our session on 11th of December 2024 on Clostridioides difficile infections. We have two fantastic speakers for this session, Trish Beckett from St. Joe's Healthcare Hamilton and Brandan de Silva from Niagara Health. Trish is a registered nurse by background with 36 years experience in acute care and mental health settings. Her background covers everything from nephrology, critical care, medicine, psychiatry, and of course, IPAC. For the past 12 years, her focus has been on IPAC, where she's gained in-depth knowledge and hands-on experience in a variety of healthcare settings, including medicine programs, psychiatry programs, and outpatient areas like dialysis. In addition to her primary role in IPAC, Trish has made significant contributions to C. difficile research, particularly in the area of fecal microbiota transplants for treatment of recurrent C. diff infections. Her work has helped advance and understand both clinical practice and research related to infection control. Our other speaker today, Brandan de Silva, is an experienced IPAC practitioner at Niagara Health. He has a strong background in microbiology, spending the first 6 years of his career as a medical laboratory technologist before transitioning into infection control, where he's worked for the past 6 years. He holds an advanced diploma in medical laboratory science from the Michener Institute and is certified in infection control with the Canadian Certification Board of Infection Control and Healthcare Epidemiology. Outside of his professional life, Brandan is a dedicated father of 2 boys and enjoys spending his free time hiking and traveling. We thank both Trish and Brandan for taking the time to share their expertise with us and hope you enjoy this session. Thank you.
Hi, everyone. Welcome to today's presentation. Brandan, go to the next slide. So what we're hoping to cover in today's session is a discussion about C. difficile, how patients acquire C. diff, and kind of patient presentation and management. So I'm going to be covering that portion of the presentation, and then Brandan will be reviewing a bunch of case scenarios at the end. Next slide. So here's our first Menti poll. So where are you currently working, or where are you practicing? So just type in the city that you work in or the area in which you work. So lots of acute care seems to be the most predominant. Kind of gets us in the how to use Menti, which is great. A little bit of public health, kind of lots of places all over Ontario, which is great. Very cool. Well, welcome everyone. We're hoping that today's presentation will provide you with a little bit of information and a little bit of knowledge to take back to your facilities. Brandan, do you want to stop that and go to the next slide? So, quick question. When would you send a stool specimen to the lab for C. diff testing? So you've got your 4 choices. After the first loose bowel movement, after the 3 loose type 6-7 stools within a 24-hour period, after 3 days of diarrhea, or after a week of diarrhea.
And just for folks trying to get onto Menti, at the very, very top of the screen there, you should see a join@menti.com with the 8-digit code. So if you go on either a separate screen or your cell phone and go just menti.com, input that 8-digit code, it should just launch you straight in and you'll get the questions straight there. If you're not comfortable using Menti, feel free to just keep throwing the answers straight into the chat as well, and folks can follow along with both.
Okay. So it looks like most of the people will send specimens after the 3rd loose bowel movement. Okay, so let's jump into the presentation. So the gut microbiota contains trillions of microorganisms that live in your digestive tract, a combined genetic material that it's at least 100 times more diverse than the entire human genome. It is predominantly made up of bacteria, but also contains viruses, fungi, and protozoa. There is a symbiotic relationship between these microbes and the human host. Microorganisms are active and perform many functions that help the human body. The human microbial population stays fairly constant over time, but alterations can have a dramatic effect on the body. A reduction in levels of the natural or native bacterial species also disrupts the ability to inhibit the growth of harmful species, such as C. difficile. Next slide. C. diff, or Clostridioides, which is a new word for me. I'm used to the old an acronym, but we'll use C. diff throughout the presentation, are anaerobic, gram-positive, spore-forming bacteria that can be pathogenic and produce toxins. C. diff can be found in many environments, including the soil. Spores can live outside of the host in the environment for long periods of time. These spores are very hardy and hard to kill with regular disinfectants. The mode of transmission of C. diff is the fecal-oral route. Any surface in the can become contaminated with C. diff and serve as a reservoir for the C. diff spore. Next slide. Once the spore is ingested, it's passed through the stomach and germinated into the colon. C. diff colonizes the large intestine, then something alters the gut microbiome, and as C. diff is an opportunistic organism, it will multiply and grow, causing patients to experience symptoms such as diarrhea. Exotoxins can cause colonic dysfunctions and cellular death, worsening the patient's symptoms. Next slide. Colonization is when C. diff is present in the stool, but the patient is asymptomatic. So typically we don't treat colonization. An infection with C. diff is when the C. diff is present and the patient is experiencing 3 or more type 6-7 stools in a 24-hour period. Next slide. There are many risk factors that predispose patients to acquiring a C. diff infection. These factors include antibiotic usage, bowel disease or bowel surgery, and immunocompromised patients, patients taking PPIs or proton pump inhibitors that alter the stomach acid, being hospitalized, increased age, and other serious underlying illnesses all increase your risk for developing a C. diff infection. Next slide. Symptoms of a C. diff infection include sudden onset, watery diarrhea with or without blood or mucousy stools, abdominal pain and cramping, low-grade fever, nausea, vomiting, anorexia, and weight loss and fatigue. Clinical indicators include an elevated white blood cell count, an elevated creatinine, and low albumin. C. diff infection can range from mild diarrhea to life-threatening colitis. Next slide. C. diff infections has a huge impact on the patient's life. You can't imagine not being able to leave your house because you're going to the bathroom 15 to 20 times per day, not being able to work or to participate in normal activities of daily living because of pain and discomfort. Complications of C. diff infection include diarrhea, pseudomembranous colitis, toxic megacolon, colonic rupture, sepsis, and even death. Next slide. So we're going to initiate contact precautions with the first unexplained loose watery stool, type 6-7. Again, this helps to contain the diarrhea and gets the investigation started quickly to prevent it being spread throughout the facility. So we're going to send the stool for C. diff. As a caveat, one of the things that we do in our facility is if the patient is experiencing nausea and vomiting, then we'll also send the specimen for norovirus. Making sure that the staff are documenting accurately using the Bristol stool chart so that we're all singing from the same song sheet. Next slide. So depending on your organization, C. diff testing is done in a few different ways. There is some debate whether C. diff PCR kind of overcalls C. diff cases. PCR testing detects the toxin gene, which tells you that it is capable of producing a toxin. However, it doesn't tell you if the toxin is actually being produced. So some suggest using a combination of ELISA testing and PCR, as this can tell you both the organism and the toxin is present. So this is why it's really important that we have a consistent surveillance definition for a C. diff infection, so that we're all classifying our cases appropriately. Next slide. Mild to moderate disease is when you have white blood cells less than 15,000, a creatinine rise less than 15% above the baseline. The first-line treatment for a mild to moderate disease is vancomycin 125 milligrams PO QID for 10 to 14 days. Next slide. Severe disease presents with a white blood cell count greater than 15,000, a creatinine rise 25% over baseline. So treatment includes supportive care, IV metronidazole, and PO vancomycin at a higher dose, so 250 to 500 QID. You can also give vancomycin rectally, so it's 500 milligrams rectally QID, which can be challenging given the amount of diarrhea that the patient is having. You also might consider doing an abdominal CT, and a surgical consult may be required depending on the severity of the disease. Next slide. Treatment for recurrence or relapse of a C. diff infection. So first recurrence or relapse, you would repeat your PO vancomycin for 14 days, or you could consider prescribing fidaxomicin, which is 200 milligrams BID for 10 days. Fidaxomicin is very expensive and is not on the formulary for most hospitals. So it's not, it is a very expensive medication. So for further occurrences or recurrences, you can consider a fidaxomicin or a vancomycin taper. So that would be prescribing the medication in a tapering dose over a period of weeks to months. The other consideration would be an FMT or a fecal transplant. One of the other things that we've done in our facility is promoted to prevent recurrence is to prescribe vancomycin prophylaxis, which is 125 PO BID, while the patient is on other antibiotics to suppress the C. diff from multiplying and growing and causing a repeat or a recurrence of that infection. Next slide. Daily management of the patient includes a daily abdominal assessment, monitoring and documenting the frequency, consistency, and volume of the stool, noting for changes in the patterns of the stool, using the Bristol stool chart, monitoring for signs and symptoms of worsening and unresolving infection. Dietary consult is also very helpful to make sure that the patient is on the appropriate diet, and also monitoring the patient's skin integrity, as diarrhea can be very toxic to the patient's skin. Next slide. Other patient considerations include assessing and possibly holding the use of medications such as laxatives, stool softeners, motility agents, PPIs, other antibiotics, making sure that alcohol-based hand rub is available at the patient's bedside for the patient to use, and encouraging overall good personal hygiene for the patient. Next slide. Some environmental considerations to help prevent transmission from occurring within your facility include initiating contact precautions in a private room with a dedicated toilet or commode, regular cleaning of a commode and running your commodes through cart washer. Ask how your staff are using their commodes and how they are handling stool and bodily fluids. It's very interesting when you get those answers and how things are being done and if they're being done appropriately. Consider reviewing hand hygiene audits, PPE audits, and other process audits, especially if transmission is occurring and ongoing. And then it's also very important to minimize the movement of the patient throughout your facility. Next slide. Other considerations include changing out wash basins every 12 hours. They become contaminated, and that will help to decrease the spread. Limiting or minimizing equipment and personal belongings in the patient's room, making sure that the room is not cluttered to help facilitate proper environmental cleaning. Cleaning and disinfection with a sporicidal agent, and cleaning the room twice a day to help keep the environmental bioburden down. Dedicating patient equipment when possible and making sure reusable equipment is cleaned between patient uses. Next slide. Key factors to prevent transmission and prevent patients from acquiring C. diff are avoiding unnecessary antibiotics, and especially having antibiotic stewardship programs in your facilities, hand hygiene, isolating patients with active diarrhea, prompt testing and treatment of patients with C. diff or diarrhea, vancomycin prophylaxis, as we discussed earlier, and then also how your facility is managing bodily fluids. Next slide. One of the common questions that we get asked by our staff are C. diff patients allowed to leave the room? So yes, they can leave the room if the appropriate interventions are put in place. So are they continent? Are they not soiling their environment? Can they or will they perform hand hygiene before leaving the room? Do they have on clean clothes, clean gown? That they only use their own bathroom or commode, and then they don't access the unit kitchen or pantry. Next slide. At our facility, we found that patient and visitor educations were key in helping keep our facility clean and our patients safe. Here's a list of some patient education topics that are important to consider and to teach when the patient has a C. diff infection. Our IPAC team meets with all C. diff positive patients and provides verbal and written instructions to patients and their families for when they're in hospital and for when they go home. Next slide. We also meet with visitors and care providers to stress the importance of following the recommended practices to keep them safe and to keep their loved ones safe. And that's it for me. Hopefully you found this information helpful. I'd like to introduce Brandan to now continue on with our presentation.
Sorry, I just had to go into Zoom here to unmute myself, and we'll get right back into the presentation. Okay. Yeah, so I hope everyone's enjoying the presentation so far. So for my portion of the presentation, I'll be reviewing some case studies with everyone. Now, when selecting these case studies, I wanted to have a broad range of skill level. So there's some more so basic textbooks type cases for more so your novice ICP, and then a couple head scratchers more so for your experienced ICP. So for case number 1, we have a 72-year-old male who is presented to a surgical unit. They were admitted with bilateral pyelonephritis, urinary retention, and post-obstructive acute kidney injury. During the course of their stay, they were treated with piptazo and ceftriaxone. Now, they were admitted to the unit for 8 days and discharged on clavulin. 8 days after they were discharged, they presented back to hospital to the ED with acute onset of profuse diarrhea. They had abdominal CT, which showed thickening of the descending and sigmoid colon, which was keeping in with diagnosis of colitis. They had an elevated white blood cell count, which was predominantly neutrophils. Their creatinine levels were elevated, and C. diff testing was done, and they were positive for C. diff by PCR. Okay. For some of these cases, there will be a lot of information. I know that's just the nature of the game with C. diff. There's a lot to look into. I'll try and go slow so that we have time to take it all in and so we can answer the questions. So how would we classify this case? Perfect. Yes. So I see we have a lot of expert ICPs in this meeting with us today. So this patient, they presented with symptoms and diagnosed with C. diff colitis within 72 hours of their admission. So they presented with symptoms on admission. And so we would look 4 weeks back to see if they had any previous hospital admissions. And they were admitted to that surgical unit 8 days prior. So this case would in fact be hospital acquired and attributed to that surgical unit. Now, what were some of the C. diff risk factors for this case? Antibiotic usage, yes. Lots of antibiotic usage for this patient. Their age, that's a great one. Yes, this was an elderly patient. Previous hospital admission. Now, I know this patient was admitted to a surgical ward, but they didn't actually have abdominal surgery or surgery of any kind. It's just at this one facility, depending on beds, sometimes the surgical unit will admit medicine patients. Perfect. Yeah. So some of our big ones here, their age, antibiotic usage, and previous hospitalization. Excellent. Now, for this next question, I'm just going to prompt everyone. For this next question, I don't want everyone to answer on what the PIDAC recommendation is. I would like you to answer what you do at your facility, okay? So when would you discontinue precautions on this patient? Would it be 48 hours of diarrhea resolution, regardless of where they are in their treatment? Or would you be required to wait for them to complete their treatment and then have 48 hours of no diarrhea? Now, there is no correct answer here. It's just interesting to see what is done at different facilities. On PIDAC, the PIDAC document says 48 hours of diarrhea resolution. There's no mention of completing treatment, but I've worked in various facilities. I've worked in hospitals where it's just 48 hours of diarrhea resolution, regardless of the treatment, or hospitals where they actually had to complete their antibiotic treatment. So yeah, this is interesting to see. So 57% do not require them to be completed treatment. And this does make sense too, because we know that when the patient is on vancomycin, that does kind of render them, if they're not having diarrhea, non-infectious, like or very low risk. One thing, I always enjoy presenting live. The thing about these virtual presentations is, I like to put a little bit of humor in my slides, but, I just hope everyone is laughing. I should put, like, I'm met with dead silence, but yeah. For me, after washing my hands for 20 seconds, 57 times in one day, appreciate the likes. Okay, so case number 2. We have a 63-year-old female who has presented to ED with abdo pain and severe constipation. They start the patient on treatment with daily PEG and lactulose. Now, after prescribing this treatment, the patient goes on to develop diarrhea. And when I use this term diarrhea, I do mean it in the term that they're having at least 3 loose stools within a 24-hour period. This patient is afebrile. Their white blood cell count is normal. They test this patient for C. diff, and it is positive via PCR. Now, no ELISA testing was done, and for all these case studies, we are just going with PCR alone. Now, the physicians chose to hold the laxatives. The laxatives were held, and the diarrhea resolved without treatment within 48 hours. How would we classify this case? Excellent. Yes, exactly. This would be classified as colonization. And before giving away the answers, we do have another slide coming up. So what factors did we consider when determining that this was colonization versus thinking infection? Laxatives, yes. Afebrile, their white blood cell count. You think, what is there a test or anything we could have done too to help us with this colonization? Diarrhea, yeah. So they have an explained reason for their diarrhea. They came in with severe constipation. We gave them laxatives. So what would we expect to happen? We're expecting that diarrhea can certainly be a cause. Their white blood cell count was completely normal. They had no signs of fever. If they had, in this case, there wasn't a CT done or of the abdomen, but we would expect not to see any colitis there. That would be another indication. And I know this case sounds kind of out there, but it is, I feel like it is a very common scenario that we see in all our organizations where we have cases similar to this. Laxatives are done, and for some reason, someone chooses to do that C. diff PCR. And now in this case too, I would feel like sometimes I've actually had to speak with my physicians. There are other reasons that the patient might need their laxatives. And so it could be that the physicians actually want them to be having that diarrhea. So as much as, so that's always a conversation to have with your physician about whether or not the laxatives could be held. When we're investigating these cases, don't feel like you actually have to classify right away. Sometimes it's best to wait a few days to see what happens. So in this case below, maybe they withheld laxatives and the patient went on to have increased loose stools and the fever did develop, right? We can't predict the future, even though it looks like it is. Don't feel pressure to classify your cases immediately. Really take your time. Sometimes it is best to wait a few days to see how the patient progresses, and you'll have a much clearer idea of exactly what your classification is versus guessing. I honestly now kind of wish that this slide said diarrhea is not a sign of C. diff infection, like alone. Maybe for next time. Okay, perfect. So case number 3, we have an 82-year-old female admitted to a surgical unit with septic shock. The septic shock is secondary to a small bowel obstruction, which had led to perforation. Now, this required a small bowel resection and primary anastomosis. That's like connecting one thing to another in like common terms. You cut it, then you got to connect things back. So following the surgery, within 72 hours of admission, this patient went on to develop diarrhea for a few days. This diarrhea resolved without treatment. 8 days later, the diarrhea returned. Now, the patient remained afebrile and their white blood cell count was normal. Their C. diff was positive, and they were diagnosed with C. diff colitis. And one thing I forgot to mention here is that there was a CT done that did show colitis. This patient was on piptazo and meropenem for 48 hours when they were first admitted, and they were on pantoprazole daily since admission. They were never given any laxatives. How are we going to classify this case? Excellent. We have some IPAC experts. Your group here is just very knowledgeable. Yes, this case is considered an HAI. So what can be a little tricky here is we might say, no, hold on. This patient was symptomatic on admission. They had diarrhea, right? They developed diarrhea within 72 hours, but we had an explained reason for that diarrhea. After resection, some diarrhea is normal, and we would expect that. Now that diarrhea, it resolved on its own and the patient was fine. And then 8 days later, they suddenly had this, they returned back to baseline, but 8 days later, they had this sudden increase in the diarrhea output and developed symptoms. Now, their white blood cell count was normal, and so that could make us think non-HAI. And in some cases, it's not our white blood cell count and fever. Those are technically, they can be supportive, but they are not diagnostic of C. diff. They did have their CT that did show colitis as well. Now, what are some of the risk factors in this case? Surgery, big one. Yes, their age. Once again, the age. PPI use. Yes, I wanted to see that. So for PPI use, our proton pump inhibitors could essentially decrease the acidity of our bowels. And with that decreased acidity, it actually promotes C. diff in its vegetative state. C. diff can thrive in that environment, and then it can lead to infection. And so this patient was on that daily PPI. They had a surgery which would put them in increased risk. They were given antibiotics early on. They are older. Now, I see a laxative overuse, but this patient never actually received laxatives. Hospitalization, yes, another risk factor. They were hospitalized for quite a period of time. Great job, everyone. Okay, case number 4. We have a 92-year-old male that was admitted to a medical unit. We'll give surgery a break for this case. They were admitted to a medical unit on September 22nd with an MSSA bacteremia. This admission was complicated by C. diff colitis. The C. diff in this case was classified as HAI to this medicine unit. The patient was successfully treated and they were discharged on October 10th. On October 20th, the patient returned to hospital with a recurrent bacteremia, and they were admitted to a medicine unit. We'll just call it a different medicine unit. Doesn't matter for this case. 8 days into their admission, the patient developed another C. diff colitis. Okay. How are we going to classify this case? You guys are so good. I was really hoping to get some people here, like a larger percentage of people fooled here, but I can't throw anything past you guys. So yeah, so in this case, it's a relapse. And the reason being, so in order to classify relapse, once a patient is C. diff positive, we look back 8 weeks to see if they had been positive within the last 8 weeks. So even though this patient was admitted to hospital and their symptom onset was greater than 72 hours, they had had a previous admission, and they had tested positive for C. diff and had a C. diff colitis within the last 8 weeks. So this case is actually a relapse. It wouldn't be another HAI case. Excellent, excellent, excellent. Okay, case number 5. On May 20th, there was an 88-year-old female who was admitted to a medical unit with acute onset nausea, vomiting, and diarrhea. The diagnosis at the time was suspect viral gastroenteritis. The patient was tested for C. diff via PCR, and it was negative. The patient during their stay were on ceftriaxone and IV metronidazole. Flagyl is the other word for that. The abdo-CT did show signs of enteritis. So we have here their symptoms resolved on May 23rd, and they were discharged the following day on May 24th. Now on June 1st, and just to give us context, so they left on May 24th. On June 1st, the patient presented back to ED. This time they had fever, an elevated white blood cell count, and an acute onset of profuse diarrhea. They were diagnosed with C. diff colitis, and they were positive for C. diff by PCR. This patient has a medical history. They were previously positive for C. diff colitis on January 3rd, and they have a surgical history 4 years prior of a subtotal colectomy and ileosigmoid anastomosis. Okay, get all that information down. I'll give you a moment. How are we going to classify this case? Oh, sorry, we'll do this one first. We'll go back to the next question after. But how are we going to classify this case? I love the little, yes, this is what I was hoping to see previously. I love this hesitation. Okay, perfect. Oh, I love this. This is going to be a good talk now. Yes. All right. So to give some history here, so this case was HAI to the previous admission. Okay. The reason being, so we might think, okay, well, they were having diarrhea, but they were on metronidazole and they improved and they were discharged, right? But if a patient was to have so at this time, one thing to consider here is that they did test negative for C. diff by PCR, and PCR is highly, highly sensitive. You're far more likely to get a false positive result than a false negative. So that's one thing to consider here. The next thing is that this patient was on metronidazole IV, and even if this patient was to have C. diff for the C. diff colitis, we would not expect their symptoms to improve so quickly. We didn't see colitis on the CT, and so this very much looked like it did fit the clinical picture of a viral gastroenteritis. It came on suddenly and went away just as fast, right? We expect with a viral gastroenteritis within 48, 72 hours for those symptoms to go away. So this was truly highly unlikely that this was C. diff at the time. So we wouldn't call this a relapse because they weren't diagnosed with C. diff prior. Okay. Now they've come back to hospital 6 days later, and now they truly have signs and symptoms of a C. diff infection. Now, the other reason we wouldn't call a relapse, I did see a few relapse responses for this case. They did have previous C. diff colitis, but that was January 3rd. And January 3rd is more than 8 weeks away from June 1st. So this would not fit the picture of a relapse, okay? And they were symptomatic on admission. So we would look back to 4 weeks and see that this was HAI to the previous admission, okay? This was a good, tricky one. I'm glad. I'm very excited. So what are some of our C. diff risk factors in this case? Yeah, previous hospital admission. Yeah. Antibiotic use. They were on that ceftriaxone, right? they had a previous C. diff infection. That was one of the new ones in this case. So they've had a known history of C. diff, which would put them at greater risk of C. diff infections. Their age, again, I know every single case we have here of all our clinical cases, age seems to be a factor. That subtotal colectomy, that abdominal surgery, that's going to put them at increased risk as well. Excellent. Not enough cheese. That's the number one reason we see at our facility too, especially when it's Swiss. You need that Swiss cheese. I'm just a thing. This is actually going to be on YouTube, so you can edit that portion out, Kevin. Yeah, the recent viral gastro. Okay. I know we're all feeling the bed pressures right now, and I'm sure a lot of us are kind of feeling this way. Okay, on to our next case. We have a 95-year-old male who's admitted to hospital with colitis. The patient has presented with an absence of bowel movements. They have rapid abdominal distension, abdo pain, tachycardia, and hypotension. Now, this patient is on treatment with vancomycin and metronidazole IV, but their symptoms aren't improving. Okay. A colonoscopy was done, which showed yellow plaques lining the colon. So we can see here in this colonoscopy, all those yellow little pockets, those plaques all lining the colon. And a CT was done, which showed a dilation of the large bowel of more than 6 centimeters. What is the diagnosis? What do we think this patient has? Yes, there you go, the nice big one. Toxic megacolon secondary to pseudomembranous colitis. So someone with pseudomembrane colitis is at increased risk of developing toxic megacolon. And one of the diagnostic features of toxic megacolon is a CT or a dilation of more than 6 centimeters of the large bowel, right? And one of our diagnostic features of pseudomembrane colitis is these white plaques lining the colon. I'll go back there just in case you want to put more responses. Colon TB. Yeah, I like that one. Oh, that's good. Yeah, extrapulmonary colon TB. That's the first case I've come across, and it was excellent, excellent. I'm thankful for everyone's participation and involvement. It certainly makes this presentation that much more engaging and enjoyable. So that is the end of our presentation. Any questions?
All right, thank you so much, Trish and Brandan. So for questions, I mean, feel free to throw your hand up if you'd like to come off mute, come on camera and ask it directly. Otherwise, feel free to throw your question directly into the chat. I will say one question that came up a few times as we went through, and Trish, it relates back to your discussion points was so hand hygiene for patients. Looking at alcohol-based hand rub versus soap and water. A few people made comments of, well, alcohol-based hand rub will hit our vegetative bacteria, but won't do anything for spores. So kind of what, thoughts on that? Where do we land on that?
So from my experience, so the challenge and the difficulty is patients don't always have the opportunity to get up to a sink to wash their hands with soap and water. So, I think absolutely that would be the best. Soap and water is bad to remove those spores. But I'm thinking of a bedridden patient who doesn't have that opportunity. So making sure that they have at least alcohol-based hand rub as a minimum to, clean their hands before they eat, or, that kind of thing.
That makes sense. I guess it's the same approach we take for staff, where, especially in an older facility where you don't have access to hand hygiene sinks everywhere, we kind of say, well, we're going to have, ABHR as our stopgap, but especially if they're visibly soiled, get your hand out to get your hands over to a sink. So
yeah, and I agree. I think we kind of do that when we see we have a patient with C. diff, is to provide that education too to staff to say, hey, like soap and water is probably your best bet here. But of course, alcohol-based hand rub is still, better than nothing, and it's still, you can still use it. But I certainly try to increase that knowledge to say, if you can, really, that soap and water is going to be kind of your gold standard in this case for our staff. But of course, we can still use our alcohol-based hand rub.
awesome. Karen Harris, I do believe you are next.
Hi, thank you. We're from Ross Memorial Hospital, and we actually currently have a patient, 24-year-old, who was admitted with a lot of the risk factors. She had recent surgery on her abdomen and came into the hospital with 3 to 4. She was put on contact isolation. C. diff was returned as positive. She has a history of Crohn's as well, so she would have fallen into the less severe category. My question is, with the history of Crohn's, her bowel movements are now down to 1 a day, but they still remain a 7 on the Bristol score. Now, in terms of removing isolation, typically we follow a 48 hours with no further loose stool and preferably a formed bowel movement before the isolation is removed. But with this patient, we've been leery because of that ongoing stool. So part of us wants to take her off because she is conscious alert. She's not contaminating her environment. However, currently she's on the obstetrics unit in a private room. So what's your thought there? I think we're hoping for her to be discharged truly, so then we don't have to make that decision. But if you could help us as a group, that's sort of what we're looking at right now.
It's always the best option, just discharge.
Discharge, perfect,
So,
John.
Has she completed her vancomycin?
Yes, actually just now.
So, and what do we know what her baseline was prior to getting a C. diff infection? I know she has a bowel disease, but is 1 loose her normal? Because you would consider this if this is back to her baseline. What I found when doing C. diff research is that patients sometimes, especially if they've had compromised bowels prior to their C. diff infection, they don't ever return to a fully formed bowel movement. Once they get a C. diff infection, they kind of always stay loose. So I think if it was my patient, I would take her out of isolation at this point.
Okay, and would you do that because she has completed the full course of the treatment, or would you have done that sooner when she returned back to her baseline?
I'm the mindset of 48 hours after completion of treatment. And, given her ability to be compliant, she's confined and contained, she's not soiling her environment, and her situation is probably back to her baseline. That would be why I would take her out at this point.
Yeah, and
Perfect.
I just wanted to add to that too. So I have worked at facilities where it is just based on 48 hours of formed stools, but actually what the policy we actually go by is 48 hours of return to baseline. And so if this patient was having 1 loose stool a day, and that was their normal prior to getting the C. diff infection, for the hospitals that don't wait until treatment is completed, if they had returned to their baseline, So 48 hours of a return to that baseline, then they would be okay with discontinuing those precautions. And of course, there's other things you can look at too, right? More than that, like, are they febrile? Is their white blood cell count still elevated? Do they have other signs and symptoms of still having an active infection? Something to consider. But it is that like back to baseline stool for 48 hours.
Thank you. That was really helpful.
And the other thing that's important to take into consideration is she's at high risk for relapse and recurrence. So you want to make sure that she's educated to know that, if she develops symptoms again, worsening diarrhea, 3 to 5 a day, that she should seek medical attention right away to get treatment, because those patients are really kind of those high risk for recurrence and relapse.
Yeah, and I know some facilities, when they have these high-risk patients who they've seen relapse, for those patients, they may choose to keep them on if they're staying in hospital because of that risk. Yeah, but that's a very good point, Trish.
All right. Thank you so much, everyone.
Thank you for the question. I love how we turn this into live clinical consults. This is great. So I'm going to so kind of two questions that can be somewhat jointed, lumped together in the chat here. So is it beneficial to initiate contact precautions in a private room and use sporicidal disinfectants after the first unexplained loose stool? And when we consider sporicidal disinfectants, should we be considering rescue RTU liquid or rescue wipes or another product?
So our facility uses sporicidal for diarrhea not yet diagnosed. It's challenging to implement because we use it doesn't always relate to the environmental service staff to switch over to that product. So there is somewhat of a gap. Whether it's a liquid or a wipe, I don't think it really matters as long as it's got the sporicidal property.
And you go kind of right at the first stool. As soon as they're stooling, you're doing. Are you moving them to a private right away, or kind of waiting to see if it comes back as anything first?
Yeah, so we don't move people until we have more definitive. So we kind of isolate them to the bed space, use a commode if they, one person would use the bathroom, one person would use a commode. So
I'd say that's similar to our approach. One of our organizations, what we trialed and had good success with is the bathrooms hospital-wide are just routinely cleaned with bleach. Toilet, sink, surfaces, everything, bleach it all, always bleach. You're always hitting the sporicide. Rescue would be the kind of equivalent of high concentration sporicidal hydrogen peroxide. But yeah, certainly that's kind of that you don't know until you don't know till you get the diagnosis, so start treating or start cleaning.
Yeah, and the facility I work with, they wait until the C. diff has actually been confirmed prior to switching over to that sporicidal. And it's done differently. I don't think one is right or wrong, and it really also depends on patient population, your organization, history. There's a lot that goes into that decision for you to make the best one for your facility.
Beautiful. Jeffrey, I see your hand up, sir. How are you?
Hello, can you hear me? Over.
Yes, sir.
Oh, just making a comment. Someone wrote in the chat, would wipes be better than alcohol-based hand sanitizer? My only comment is alcohol-based hand sanitizer is not ideal. We're all discussing, gold standard would be soap and water. And again, just availability and ease of use. The problem with wipes, I find, is the risk for cross-contamination. So coming from an operating room background, just to do my surgical hand scrub with alcohol-based disinfectants, there's a process to follow. So we're not going to use that and educate that to our patients because, especially with the age and cognitive limitations, that would just be ludicrous. Then, if I remember in the operating room, again, when I use soap and water for my surgical scrub, there's a way to dry my hands with the sterile towel. So again, that issue of using wipes, would it necessarily be better? Possibly, but you got to be mindful because there's a high risk of cross-contamination because soap and water, solution pollutions, dilutions, all going down the drain. You're not touching the sides of the sink, but the wipe, unfortunately, will be a fomite that unfortunately will possibly harbor the spore, and now is a cross-contamination not only to the person but maybe to the environment, right? So you gotta sort of think it out. So if you have nothing else but wipes, because let's say you have limited soap and water access, yeah, but then just remember base principles. Over.
Fair enough. That's a great point. And yeah, that idea that if you, especially soiled, your hands are soiled, you wipe it with a washcloth. That washcloth is now soiled. And so you're not just putting it back on the bedside table to be used next time you need to wipe your hands. All right. So with that, it is 1 o'clock. And so the last just quick closing points here. So Rodora from Public Health Ontario has mentioned that we have fantastic IPAC learning module from PHO on C. diff infection case scenarios. So that's listed in the chat there. A reminder again, as you exit the meeting, you should get a pop-up in your browser with the ability to give some feedback for this. As well, if you are interested in IPU certificates, your name and email. If you, for whatever reason, don't need that, there's multiple people in your room, you just have trouble getting it, shoot me an email, kstinson@smgh.ca. I will throw that in the chat here, and I will get you, I'll get you sorted out with an IPU certificate. Thank you, Trish. Thank you, Brandan, for your fantastic time today and your expertise. And thank you all for joining us today. Happy holidays. Hope you have a fantastic holiday season. Our next session of this will be tentatively for the 2nd week of March, and we hope to see you all there. Thank you very much.